Namaskar, everybody. For inviting me to speak on this important this. Mental health is usually discussed, as discussed by Sagarji also, that as a medical or a public health issue. But when a person is denied the care, he is subjected to discrimination, abandoned by the families, unnecessarily detained, or unable to seek legal protection. It becomes an access to justice issue. India has already had it. We have already have a legal and policy framework. The challenge before us is to ensure that these rights are actually experienced by the people, particularly those who are poor and vulnerable, socially excluded, or unable to speak for themselves. So, my focus, as mentioned by the director, sir, is therefore on moving from a legal entitlement to a lived experience, which usually would be talking about the topic that towards a responsive mental health system, legal safeguards, policy priorities, and access to justice. To understand this better, let us first look at the situations in which the mental health concerns becomes an access to justice concern. A mental health condition does not automatically becomes a legal issue. It becomes an access to justice issue when dignity, autonomy, safety, and equal treatment is denied. This can happen within the family. For example, in case of domestic violence, abandonment of an older person, neglect of a child, denial of property rights, or exclusion of family from family decisions. It can happen during contact with police or the custodial system when the person is in distress is treated primarily as a threat or an offender rather than someone who may need care and protection. It can happen within a health facility when the treatment is given without adequate information, privacy is violated, the person is subjected or to degrading treatment, or no mechanism is available to raise a complaint. It can also happen at schools, workplaces, and communities to discrimination. Fortunately, India does not have to begin from the beginning. The legal foundation is already strongly right based. The Mental Health Act 2017 marked an important shift from largely institutional and custodial approach to rights based approach. It recognizes access to affordable and good quality mental health care as right. It protects autonomy through informed consent, advanced directives, and nominative representatives. It also protects the dignity, privacy, and confidentiality. It provides protection against cruel, degrading, and inhuman treatment. Another important principle is the right to live in the community, as was mentioned during the initial opening remarks. A person should not remain in a mental health institution merely because the family is unwilling to accept him. The Act also recognizes the right to information, access to medical records, grievance redressal, and free legal services. The Rights of Persons with Disability Act provides an additional framework for equality, non-discrimination, reasonable accommodation, and participation in the society. These laws reflect our constitutional values of equality, liberty, and dignity. The issue, therefore, is not absence of rights. The issue is whether the person and family can actually exercise their rights when they need them. This brings us to the most important concern, the gap between the right written in the law and access as experienced on the ground. There are four important gaps. The first gap is the awareness gap. Many people, families, and even frontline workers do not know what rights are available, where services exist, and how a complaint can be made. The second is the coordination gap. Health services, police, legal aid, disability services, social welfare department, rehabilitation institutions, they often work separately. सब अपने अपने अलग अलग काम करते रहते हैं. The third is the continuity gap. A person may receive treatment during a crisis, but medicine, counseling, family support, rehabilitation may not continue after discharge. जैसे कोई पेशेंट आया है उसको एक बार ट्रीटमेंट दे दिया बट फॉलो अप कोई करता नहीं उसमें. दैट्स अनदर गैप विच इज देयर. The fourth is accountability gap. The grievances often receive attention only after serious harm, media coverage or litigation. हमारे पास कोई व्यवस्था नहीं है. किसी ने कंप्लेंट किया कि हाउ टू एड्रेस हिज कंप्लेंट, हाउ टू डिटेल्स हिज कंप्लेंट, अनलेस ये बहुत ज्यादा एस्केलेट नहीं हो जाए मैटर तब तक कि वी आर नॉट एबल टू एड्रेस दैट थिंग. Telemanners, which is available through 11416, that's the helpline number, is provides an important national entry point for counseling and referral. But a helpline should be a doorway into care, not a substitute for functioning local services. हम लोग ने हेल्पलाइन में हम सोचते हैं कि हेल्पलाइन हो गया तो हमने सर्विसेज दे दिया, बट इट्स अ डोरवे टू केयर, नॉट एज अ लोकल लेवल पे कोई व्यवस्था कर दी भैया हमने हेल्पलाइन बना दिया काम हो गया, वो नहीं है. The real bridge between the entitlement and access must therefore be built at the district and the community levels. That's the challenge. So I would suggest 5 practical bridges that can help us to build a more responsive mental health system. The first bridge is to from the law to the service. The first bridge we have to create is law to service. Every important right must be linked with a clearly identified local service. A right to mental health care has little meaning when the family does not know where the treatment is available. The second is the healthcare and the legal aid. District mental health program teams and the district legal services authority need a two-way referral arrangement. Health professionals should recognize where when the legal protection is required, and legal services providers should know when timely mental health care services is to be provided or where they are available. The third bridge is from institution to community. Discharge should not end at the hospital gate. It should include medicine, counseling, family preparation, social protection and rehabilitation. हम लोग खाली पेशेंट को मेडिसिन देते हैं उसके बाद छोड़ देते हैं बट इससे बहुत आगे की तरफ जाना है मेडिसिन के अलावा काउंसलिंग करना है फैमिली को तैयार करना है सोशल लेवल पे हाउ वी कैन प्रोटेक्ट दैट इंडिविजुअल एज वेल एज द रिहैबिलिटेशन जिससे आपसे काम काज करने वी हैव टू फोकस ऑन दैट द फोर्थ ब्रिज इज फ्रॉम क्राइसिस कंट्रोल टू क्राइसिस केयर वी आर ओनली फोकसिंग ऑन द क्राइसिस कंट्रोल अभी जो खाली जो कुछ भी इशू होता है उसको किसी तरह से नियंत्रण करना है बट वी शुड फोकस फ्रॉम crisis control to crisis care. Police, ambulance personnel, emergency departments, magistrates, and shelter room need common protocols based on de-escalation, safety, and dignity. Everybody should be taught. जितने लोग handle करने वाले हैं mental patient को, they all should be sensitized in handling this patients. The fifth bridge is from routine reporting to accountability. We must measure where rights are actually protected, not only number of consultations conducted. अभी खाली हमने कितने परामर्श दिए हैं उसको खाली काउंट करते हैं बट हमारा जो मॉनिटरिंग मैकेनिज्म है वी शुड सी दैट हाउ मेनी राइट्स ऑफ द मेंटल पीपल दे आर बीइंग प्रोटेक्टेड दैट वी शुड मूव फ्रॉम जस्ट काउंटिंग द काउंसलिंग टू जस्ट मेजरिंग कि हाउ मेनी पीपल विद राइट्स people rights are protected. Every district therefore needs a visible, simple, accountable mental health justice pathway. We have to see that how we move toward that. Let me illustrate what such district pathway look like in practice. The pathway begins with when the distress is identified by the person, the family, a community worker or paralegal volunteer, the police or the another way. The pathway starts from that. The first response may be provided through Ayushman Arogya Mandir. We do have around 1,80,000 Ayushman Arogya Mandir, which caters to a population of 3,000 to 5,000, depending on the population norms on which the center is there. The primary health center or the telemanas, the facilities there. The purpose is at this stage is to listen, assess immediate risk, and connect the person with appropriate care. उस लेवल पे ऐसा नहीं कि ट्रीटमेंट पूरा हो जाएगा तब एट दैट पॉइंट ऑफ केयर सुनना है उसको उसकी प्रॉब्लम को एसेस करना है then if it is required need to connect with the higher centers like community health centers or district hospital. When a clinical care is required the pathway should lead to community health center, the district hospital, the district mental health program team or a higher referral facility, a medical college because प्राय अभी थोड़े दिन में most of the district hospitals districts would be having medical colleges. So we have to see that how a connect is made between the Ayushman Arogya Mandir, the Telemanas, the community health center and the higher referral centers. When there is violence, unlawful detention, property deprivation, discrimination, abandonment or denial of entitlement, the person should also be connected with the district legal services authority. The legal helpline also provides another access point. But the referral is not the end of the pathway. The system should follow person throughout the treatment, medicines, counseling, social protection, disability related support, wherever it is applicable, rehabilitation, grievance redressal. The pathway must remain connected until an outcome is achieved. So this is where the para volunteers or the legal literacy partners can play a very important role. The legal volunteers are not expected to diagnose or treat mental illness. Their role is to help a person enter the right pathway with dignity. I would emphasize the role of four simple actions. Role with simple four actions: recognize, respect, refer, and remain connected. पहले त्वरित पहचानो उसको, सम्मान दो, रिफर करो या फिर एंड रिमेन कनेक्टेड. इट्स नॉट ओनली रिफर करने के बाद छोड़ दी मैंने उनको नंबर दे दिया दैट नॉट रिफरल. नंबर देने के बाद वी कनेक्टेड वेदर द पर्सन हैज अवेल्ड द सर्विसेज एंड व्हाट इज द आउटकम ऑफ दैट सर्विसेज दैट शुड बी देयर. Recognize means we have to see that the signs of distress, neglect, violence, homelessness, exploitation, and denial of health services start to be recognized. We have to respect the individual. We have to speak calmly, maintain privacy. ये काफी भारी भारी शब्द है जो बोल रहा हूँ, बट प्राय कोशिश करेंगे तो दिट कैन हैपन, बिकॉज इन मेनी ऑफ द private institutions or other institutions, they always see that ki how empathetically they can speak with the patient calmly, quietly, routinely also. Maintain privacy, listen without judgment, and avoid stigmatizing labels. You see that we are still challenging. Mental health is also a very difficult thing to handle, but we still have challenges with the other tropical diseases where stigma is associated, and that results in a lot of mental trauma. A person with mental health condition should not automatically considered violent, incapable or unreliable. हमको लगता है कि अगर कोई मेंटल डिसीज है वो वायलेंट ही होगा, ऐसा नहीं है. So we can always find a way in handling that person. We have to refer the person to local health services, the telemanas, district legal services, or there is an appropriate authority. If he requires a legal services, he should be connected with the legal person. If he requires a mental services, he required to be connected with the health services. Finally, remaining connected, that means check whether the person actually received care, protection or legal assistance. यहाँ पे हमारा दायित्व पूरा होता है. That means whether the person who has been referred, whether he has received the care or not. उसके बिना नहीं छोड़ना हमें. उसको केयर मिला कि नहीं मिला, मिलने के बाद क्या हुआ, that kind of connect should be there. Given a person telephone number is useful, but it is not completed referral. The effectiveness of the system depends on whether the connection results in meaningful support. From this pathway to work consistently, few changes are required in the way services are organized and monitored. Four areas need attention. First, every district should have an assured mental health service package. This should include outpatient care, essential medicine, emergency response, referral, counseling, follow-up, and rehabilitation. In IPHS, we already talk about that. In the mental health program also, some elements are there, but we have to see that how a package of services is being provided. Second is we require a joint operational protocol. Hospital, police, ambulances, magistrate, legal services, and shelters should not follow unrelated procedures when dealing with the same individual. We see that how the previous slide when I have told about the how we remain the referral should be referral and the reconnect. That's the most important thing. And I think if we have the joint operational protocol, that reconnect can happen. Third, we must strengthen community living and reintegration. Treatment alone is not enough. Many people need family counseling, supported accommodation, livelihood assistance, and access to social protection. Fourth, we require rights-based monitoring. In addition to service number, we should track legal aid referrals, complaints, involuntary care, use of restraints, discharge, follow-up, rehabilitation, reports of abuse, and abandonment. The test of this reform is not only whether the program exists, the test is whether the person and family experience continuity, dignity, and effective remedy. I will conclude with three commitments that can guide both the health systems and the justice system. The first commitment is care close to the home. People should be able to access basic mental health care without traveling long distances or waiting until a crisis appears. Here comes the role of the telemanas services and our Aishman Arogya Mandir. You see that we always believe that the access to care should be as near as possible to the people. The second is the dignity at every contact, whether it is first contact with the health worker, police officer, lawyer, magistrate. There should not be no stigma, abuse, unnecessary coaction or abandonment. Nowadays, in the urban elites, though people they start coming up with their mental problems, but still in the rural areas, a lot of stigmatization is there, unnecessary abandonment is there. The that kind of problem is there. The third is no one is left without support. Treatment must be connected with legal aid, rehabilitation, social protection, follow-up, and whenever required. Mental health care is a health service, but access to mental health care is also a legal entitlement. The real bridge between law and care is another institution. It is coordinated action at the district and the community level. Thank you very much. Thank you once again, Department of Justice, for giving me this opportunity. Thank you very much.